All right, so a couple of questions that I had so far through the environmental emergency lecture. One was about procainamide or proparacaine, that's the eye drops, the numbing eye drops. A nurse is able to administer those with an order. Sometimes in the emergency department, we'll use half of a Tylenol and we'll drop the other half and we say, I can't give this to you, but in 6 hours it's due and I'm just going to throw it away. So I'm just going to leave it on the computer here, and then I'm going to leave. So it just, it's giving the patient another dose. But we absolutely cannot do that with proparacaine or procainamide, the numbing eye drops, because it works so great. So the patients will just overuse it. And unfortunately, it causes a lot of vasoconstriction in the eye, and we can have lots of problems. They actually just did a study not too long ago and the study revealed that, probably not as many problems as we initially thought with the numbing or with the vasoconstriction and the problems associated with that, but still it's not something that we should be administering to ourselves ad lib. So I hope that answered that question. And then there was another question that came in, and it was about frostbite. And it looked like in my slide it was pretty contradictory, where there was about a 90-day where there was necrosis, and then the old adage, a frostbite in January and an amputation in July. They actually, both of those things are true. It takes about that long to see the extent of the for the body to have that necrosis demarcation. But it takes, that much longer, three months or so, to figure out, like on the medical end, the extent of it. So normally they do kind of wait a few months for that to for the amputation to happen. Was there any other questions? Cindy, you said you had a couple.
I do. On slide 20, this is a slide about fever in children. You're talking about the fever in the neonates requires the septic workup, and then the baseline labs are CBC and BMP are listed on the slide. And then you said verbally procalcitonin and one other thing, which I could not figure out what you were saying.
Oh, I'd have to go back. Probably was it NSAID rate, maybe?
Yes.
Okay.
NSAID rate, what is that?
Both of those are inflammatory markers. They use procalcitonin.
Oh, the
ESR.
ESR. Okay.
Yeah.
Sorry.
So the procalcitonin is more of the gold standard right now, but you will see, some of the older docs use the NSAID rate too, but both of those are inflammatory markers. Yeah, okay. And in the neonates, so once again they just changed these guidelines to make it a little nicer on the neonates, but it's not good when they have fevers. Something is wrong. So if you can find the source of infection, then you don't have to do the entire septic workup, including the lumbar puncture. But if they don't know the source of infection, that it includes everything. So these poor little kids that are younger than, either younger than 30 days or younger than 28, I'm not gonna hold you to those numbers because they differ in varying colleges there, but it's a full workup. We're doing the urine catheterization, you know, we can't just use the urine bag. We have to, you know, get a chest x-ray. They do the lumbar puncture and they're getting fluids, and it's just sad all around for these little guys, but
If Cindy's done, can we go back to the amputation? I'm still a little confused. So I understand what needs to happen. There needs to be a period of time to make sure that the damage extent is clear, but I am unclear if that stops at 3 months or 6 months still.
the
Or do we
damage,
need to know that specific? Maybe I'm
you
just
don't,
digging deep.
you don't need to know that specifically.
Okay, thank you. That's what I care about, really. Okay,
Not at
thank
all.
you.
But to answer that question, it's about 3 months, and then it takes another about 3 months to figure out on our end what that looks like.
Okay.
Yeah.
So up to 6 months. Okay, thank you.
Yeah, 3 to 6 months. I'll also make an announcement of a really great article that has you know, hypothermia and frostbite in it, just for your reading pleasure there. All right, any other questions?
I actually just wanted to ask, oh, I'm sorry.
No, go ahead, Cindy.
I just wanted to ask one more thing about the cocaine that you mentioned. Was that for epistaxis?
Mm-hmm. Yeah,
Okay,
we use it.
So how is that administered?
It's a topical solution, or yeah, they're drops, but you put them on a Q-tip, and then you put the Q-tip up into the nose. It's a heavy vasoconstrictor.
Okay.
And
And
it
you
adds
just like
and it adds
use it-
some you know, some anesthetic to it as well.
okay, this is a dumb question, but do you like stick it up there and leave it up there, or do you're just trying to apply it? I'm just trying to figure out how you're going to apply it. If the nose is bleeding, it's all going to just run out. So do you stick it up there and leave it?
No, you just stick it up there and apply it.
Okay.
So hopefully it helps with the vasoconstriction of just the bleeding area.
Okay, thank you.
No, Chandler, that is not how we use it in the ER. And it's only 3%. And you do have to waste it, it's controlled. Yeah, I've never done, yeah, either one, but I've experienced lots of patients that thought that they were snorting cocaine only around here. And that tends to be another drug that gets laced with other things, particularly methamphetamine. So be careful with your recreation. All right, Sydney.
Yeah, I just had a couple quick questions. So my first question, you said that you're going to open the quiz after this class.
Uh-huh.
Is that right? And then
Oh
how
yeah,
long will...
it won't be due till Friday.
Oh, till Friday, sweet.
Yeah.
And then my second question, because I wasn't able to open if there is a lecture for tomorrow, or is that just live?
So next Tuesday we're gonna
yeah,
be. It's just yeah. I don't know why that was there. That was from last year. My live lecture from last year. So yeah, I'll just be doing a live lecture on that.
So nothing to listen to before our next class. Sweet. Okay. Thank you.
Yeah, the first week is really heavy, and then after that, it's not so bad here in emergency theory land. Oh, so raise your hand if you're done with clinicals. I have a few. Awesome. Getting exciting. Oh, I guess that's tomorrow. Yes. We're in the home stretch. Okay. Well, like I said, this lecture won't take the entire 2 hours, won't take long at all. And I am not going to call on people because it's a very sensitive topic, and some people have a hard time picturing it objectively right now. So I will not be forcing you guys to talk if you don't want to. So we're going to talk about sane nursing. SANE stands for, doesn't anybody know that?
Sexual assault nursing examiner.
Yep, sexual assault nurse examiner. Yep. So I did this lecture as a guest lecturer 3 years ago, and I said, man, that was fun. I should apply it at CBC. So this is how I actually got a job at CBC, or interested in teaching. But this was in there, and I thought, well, I'll keep it in there. So it's really now time, you've been told all along how you're supposed to be a nurse. But now's a great time for you guys to think about what kind of nurse you want to be. And if you've had clinicals with me, I always ask that, not what kind of nurse, but what kind of nurse you want to be. And it's really great when you're first starting to tell your preceptor, or the person that's going to be orienting you on the new job, what kind of nurse you want to be. I've had all sorts of different answers, and I try to really, as a working teacher when I was working at the hospital, guide that person to the kind of nurse that they want to be. So some nurses say that they want to be the one that everybody goes to if they have a question. They want to know everything. And some say they want to do, one-on-one, teaching with the patient. They love teaching. Or some say that they just want to be the most compassionate nurse they can be. So I really encourage you guys to think about what kind of nurse you want to be. And it's really good, to have a motto for yourself. So it says hospitals, schools, and meerkats have mottos. So I encourage you guys to kind of think about what your motto is. By the way, CBC has a motto, right? A mission statement. Do you guys know what that is?
There's a joke here.
There's no joke. There's no joke. I looked it up this morning. Columbia Basin College inspires, educates, and supports all students in an environment of academic excellence, leading to the completion of degrees, certifications, and educational transfers while fostering meaningful employment, engaged citizenship, and a lifelong joy of learning. So CBC has a motto, so I encourage you guys to have one too. There's no joke. Okay, so let's get into the topic. What is rape? So different states define rape in different ways. In Washington state, rape is defined as forcible sexual intercourse without the other person's consent. The forced use can be physical or emotional. So Washington has a pretty liberal view of what rape can be. So threat, intimidation, pressure, and coercion. And then of course I have to ask, what causes rape? Would it be provocative dress, use of drugs and alcohol, being a college student, flirting?
Neither of
Those are
them.
all victim centered.
Oh yeah, I love that. So yeah, what causes rape? It's rapists that cause rape. But being a college student actually raises your risk of it. They say about 1 in 5 college students have experienced rape females. So a couple of rape facts. This is, you guys, a subject that is near and dear to my heart. I actually did my thesis on this for my first master's. So rape in 2016, there were 2,259 reported forcible rapes in Washington state alone. And reporting is not something that happens very often. Estimated yearly rape of a woman is 300,000 to 1.3 million. And the number varies so much because it is such an underreported thing. So they say a woman's chance of being raped is 1 in 5. Native American women, 1 in 3. Chances of incarcerated person raped in prison, 1 in 10. 1 in 10 rape victims are male. And the likelihood a woman will be raped over getting breast cancer is 2 to 1. So it affects many, many people. Okay, there's quite a bit of rape myths. The first myth is that a rape is nearly always completed by a stranger. And in fact, this is actually the minority of people will have a rape completed by a stranger. It's usually some form of acquaintance, relative, even a spouse. Another fact or myth is that weapons are involved. And in fact, in most cases of rape, weapons are not involved. Obvious physical injury. I think the statistic is about 11% of people that come in with a rape have no physical or have a physical injury. The rest have no physical injury. This is a big, huge pet peeve of mine because the cops come in and they ask, well, were they raped? That really bugs me. Okay. Another myth is the victim is hysterical. We all know through our trauma course that we had that we respond in very different ways, and hysteria is very low on that totem pole of how we will actually act. Another myth is the victim will report immediately. And then I have to ask you guys as a whole, what are some barriers to reporting?
Fear, especially if it's someone you know.
Yeah. So fear of safety or getting them in trouble or?
Well, safety. I think even the fear of getting them in trouble is still a fear of safety because fear of recrimination or further
Mm-hmm. Yeah.
assault
It
or
could be
damage.
like tearing the family apart or even deportation.
Yeah, yeah, those are big ones. Any other barriers?
Maybe not remembering. I can just real quick, since we're on this topic, I can share this. I'm doing my preceptor at Lord's Counseling.
Mm-hmm.
We had a patient come in the night before yesterday, and she's a rape victim. And they found her with no clothes on, pretty banged up. So I spent the whole day with her yesterday, and I had to do a lot of wound care on her.
Mm-hmm.
But I asked her, she's homeless, but I asked her you know, if what she remembered, and she just remembered very little. So I think I asked her, do you think you were drugged? And she said yes. And she just knew that when she came to, there was still one of them on top of her. And she was able to get away, and somebody called for help. But anyway, she was with us now, but yeah, very sad situation.
Yeah, boy. So yeah, you touched on a few things there. They might have fuzzy details, or, you know, hey, I was using some drugs voluntarily, you know, so fear of getting in trouble there. Or yeah, you just don't remember. Wake up in an odd spot.
I
Or...
have two things. So one is, I think when somebody reports charges, for some reason, it tends to be the victim is on trial instead of the person that's done the act or accused of doing the act, where they have to justify that they didn't bring it on, or, you know, they kind of get the roles reversed in rape, whereas untrue for other crimes. And then the second thing, so obviously they may not want to be put on stand for their entire life because something happened to them unwillingly. And then the second thing is, I cannot find these PowerPoints on the shell in Canvas. Are they up?
I'm
Oh,
not finding it either.
I haven't put them up, but I can.
Thank you. I'm just like, is it just me? Is everybody else with it and I can't find them? Thank you.
Well, hopefully you're following along right now.
Well, I am, but I'm trying to find them too. And I'm just like, I cannot find them. Thank you.
Anybody think of any other barriers to reporting? Yeah. Well, I guess like now's a good time as any. I myself was a victim of rape about almost 5 years ago. It'll be 5 years ago, July. I'm at my house and I'm playing Candy Crush in my front porch, and some neighbors that I hadn't met asked me if I would like a drink, and I said no thanks. And then they came over about 20 minutes ago or later and asked me if I smoked, like smoke weed, and I said no, I don't do that, I'm a nurse. And so they said, oh, you're a nurse, you know, I've got neighbors kind of coming around me. They said, you know, where do you work, and do you know so and so? And you know, we had this kind of friendly neighborhood chat, and one of them offers me a candy, and of course I take candy, but the candy had marijuana in it. Anyways, I felt dazed and confused and went home. And then one of them broke into my house and raped me. And so I woke up and I immediately thought, I can't report this. You know, if I report this guy is my like neighbor, and I will have all sorts of safety issues with that. And then I'm kind of like loopy and out of my mind. I don't know what's exactly going on. I had lots of fear issues. And then at the end, I decided, what if this was one of my friends or my daughter? And so I did report right away. And I went to the hospital and I got my kit, and the Kennewick police officers took my report, and they came back with a photo montage, and I identified the fella, and right away he was arrested. And we went through this whole process after he was in jail of him wanting a speedy trial, because apparently they knew that these rape kits took forever, and the prosecuting attorney saying, we really need this rape kit. And then finally he had pretrial and pled guilty to burglary and rape, and is now spending 7.5 years in prison. So the whole process for Karina, who has done rape kits before, who's aware of the process, who had done nothing wrong, was completely scary for me. So I could totally understand all of these barriers to reporting. And in Washington State, they have this really fabulous thing that you could do. You could actually get the kit collection and take care of your needs at the hospital medically. And we can save the kit for a while before, so they can take time to report on their own time. Usually about 30 to 60 days is how long most places will hold that kit. Or you can get the kit done and have it sent to the Washington State Crime Lab anonymously. And when they send it anonymously, they will enter the DNA into CODIS, and CODIS is the big bank of DNA. And when they have, potentially like a repeat offender situation, then they can charge the person on more than the one count of rape. And somebody actually did an anonymous report a long time ago, and that's how they got enough DNA to do the forensic workup for the Golden State Killer. So that's kind of a cool thing. So I happen to be thrown into the whole legal aspect of this as well. So if you guys have any questions about the legal aspect, I'm pretty up on that one as well. But the first thing I thought of was I cannot possibly report. And you don't have to if you are over the age of 18 or are not a vulnerable adult. You can do that reporting on your own. So lots and lots of barriers to rape, but the forensic collection is just one of the things that they do in the emergency department. We also take care of them, obviously, medically as well. Anybody have any questions? Okay, so let's talk about my first SANE kit. This was, I don't know, maybe 8 or 9 years ago, and I'm working day shift, and the night shift nurse says, oh, there's a rape in room 3. It was actually a terrible case. It was a 15-year-old. And she'd been there for about an hour, but they didn't want to start the kit because the kit takes about 3 hours. There's a detective outside the room, and she tells me some details of my new patient, but hurry up because they wanted to bring her into the police station for questioning. And the girl was a victim of sex trafficking. And I had 0 educational experience on the matter, and this is exactly what I looked like, was this little baby. I'm like, what? How do I even start? So on this day, I was a really bad nurse. But part of my motto is to be a good nurse. So I changed. So I went to a SANE class. In Washington State, most nurses are SANE trained instead of SANE certified. In order to be certified, you have to have observation from SANE certified nurses, and there's just not a whole lot of them out there. So most of the nurses in Washington State are not SANE certified, they're SANE trained. But in Oregon, you have to be SANE certified. So just know where you are when you're working, what the laws are. So I went to all of the training, and while we were at the training, we discovered that the hospital wasn't doing that collection or the safekeeping We didn't have an opportunity to take pictures. There was like a whole bunch of things that we did wrong. And so I'm happy to report that we created an action committee, a task force, and we implemented a lot of new policies at Cadlic for the forensic collection, and they're still being revised to this day. So there's still some interest in there. And I always say, if you don't like change, you are definitely in the wrong profession, because nursing is all about changing. All right, so I will tell you about the role of the sexual assault nurse examiner. First of all, we are going to be providing that trauma-informed and competent medical care. Can anybody tell me what trauma-informed care looks like? I keep thinking of that video I showed you guys back in your mental health theory, where they had the big Scottish voices. Do you guys remember that cartoon?
So I think that process focuses, well, specifically thinking of like the interview type situations, the questions, is focusing on the act itself and the experiences of what the person was experiencing. Instead of trying to make them draw conclusions or things like that. Just, well, what did you see? What did you feel? Did you smell anything? Did you hear anything? You know, what happened to your body? And just kind of focusing on all those aspects of it, rather than, well, why do you think this happened? Or things like that, that might make them feel, again, that they are being blamed for the situation.
Great.
Or just kind of shut down the ability to recall and provide information.
Yeah, great. Anybody else want to expand on that? Okay. And then the sexual assault nurse examiner also educates the patients about their legal options. So we do need to be aware of legal options ourselves. We'll go over a little bit more about minorities or minors, because it gets kind of a little hairy there. And then we collect forensic evidence with the patient's consent. So we do not do anything to re-traumatize that patient. Everything is through their consent. We document injuries, and we do it in a way that we're using all appropriate medical words. These cases I've been subpoenaed lots of times to go testify in court, and you really have to it's really humbling when you look at your own documentation. So you want to make sure that we're documenting like crazy. We provide prophylactic medications. So prophylactic may mean if they are not on a consistent birth control, we can offer the patient an IUD. Oftentimes in rape cases, unless the patient wants it, we do not test for STDs first, or STIs first. And the reason why we don't is because it's really not the court's business whether this patient had a pre-existing STI. It could make them look, just like Cindy said, a little victim blaming there. Well, they're already a promiscuous person with an STI, lots of conclusions can be drawn from there. So we oftentimes will prophylactically treat these patients with the STI medication. So right now the recommendation is IM injection of Rocephin azithromycin 1 gram and Flagyl 2 grams. Yeah, I will not be requiring you guys to know those things. But you're basically treating trick, gonorrhea, and chlamydia with those. And then it gets even a little bit more into the woods with a prophylactic medication for HIV. That requires a pretty strong commitment on the patient's part. It's 30 days of medication with a pretty big side effect of nausea and vomiting. So they don't like taking it to begin with. It can really interfere with their liver enzymes. So they have to get a couple of blood draws during that time to make sure that their liver enzymes haven't increased. And depending on the nature of the rape, there may or may not be a large capacity for requiring that anyways. So prophylactic meds, that's what we mean when I mean prophylactic medications. And then the sexual assault nurse examiner assesses for safety and safe discharge. And they're going to collaborate with other team members. Here locally, they have SARC, which used to stand for Sexual Assault Response Center, but now it's Safety Advocacy Resource Center, I believe. And then we collaborate with law enforcement, make sure that we're doing the forensic collection according to law. We might have to collaborate with prosecutors and also defense attorneys. Defense attorneys are not on your side. I've had lots of meetings with them too. They're not fun. So what the SANE nurse does not do, we don't determine whether a sexual assault has occurred. Like I said, this is a huge pet peeve of mine. That is up to law enforcement at that time. All right, so we'll talk a little bit more about that trauma-informed care. So during and after the trauma, the brain goes into survival mode. Do you remember that? We got the fight, flight, freeze. And I think everybody believes, you know, in their heart of hearts, if they were going to be a victim, they would fight, right? But freeze is actually typically what we tend to do. So there might be a lot of guilt that's associated with our own response to the trauma as it's happening. Remember that hippocampus, which stores memories nice and neat, during that fight, flight, and freeze time, basically shuts off. So we have a hard time remembering things. Repeated abuse may make trauma symptoms worse. We all know that. The alarm systems go off more and more and more, and all of a sudden we're frazzled. People may behave in unexpected ways. You can't tell a trauma patient how to act. And trauma is a normal human response to an abnormal event. All right, so I'd like you guys to tell me some trauma symptoms.
Flashbacks.
Yeah, flashbacks.
They can be like withdrawn.
Mm-hmm. Yeah, for sure. I know after my rape, I was really mad at anybody that like wouldn't talk to me, or like that treated me different or wouldn't talk to me. I'm like, hey, we're friends. You know, a lot of people just didn't know how to talk. But my ex-husband, he says, you know, you shouldn't take candy from strangers. And, you know, we got a good laugh about that. Like things like that, I think are important. But usually the relationship that you've had with your friends before, you want to continue having that. Any other trauma symptoms? All right. All right, and of course, I want to talk to you about burnout again. That secondary trauma that's resulting from caring for, hearing about, or witnessing that intense suffering of others. And we will likely internalize that trauma. And then just think in your own ways how you are going to combat what you might be witnessing as a nurse. Okay, so during that medical forensic interview at Kedlick, we use a written flow sheet, so we'll be there with, not in front of the computer, but with our little clipboard in front of the patient. The patient gives a brief narrative of what happened, and more or less, they'll use this in the crime report, but we really want to know about other injuries. So such as if they were choked, that takes us down a whole bunch of different pathways. We need to make sure that the patient's airway is okay. We usually do a CT scan and make sure that they have somebody that's going to be able to watch them for 24 to 48 hours. Then we, help them make that report. We usually call law enforcement on their behalf. We need to know if they were restrained, hit, kicked, thrown, bitten, strangled, or other force. If there was substance or suspected substance use, just like in the case of Jennifer's patient. What the specific nature of contact was, whether it was penis, digital, a foreign object, to the mouth, vagina, or anus. What their post-assault activities were, if they showered already, if they urinated, defecated, they rinsed their mouth, ate, drank, changed clothes. And then we do, the review of systems on that patient. What's hurting on you? And then what happens in the exam? The patient guides the exam and can stop at any time. And I make sure that the patient knows that, that we can stop at any time. Do I have your permission to do this? Everything is patient-centered and patient-led at that point. The nurse provides a head-to-toe exam assessing the injuries, and they'll definitely do written documentation of the injuries, but they may also take photos. The photos are done 3 feet apart, like kind of a broad view, and then a closer up view, about like 1 feet is what you want, depending on the injury there. And then have the patient's label. Those get all, they do not go into our medical record. Those get sent with law enforcement. We do swabbing for evidence. We do oral, fingertips, reference blood, perineal, vulvar, vaginal, anal swabs. And then as indicated, we'll take trace evidence, toxicology, debris on skin, skin swabs, pubic hair combing, and I'll go over that when we open the kit. And then the nurse does have, it is within the nurse's scope of practice to do a pelvic exam with a speculum, but that's really only as indicated, to visualize any injuries and if there's any hemorrhagic bleeding that we need to take care of. The exam takes 2 to 3 hours. It's really lengthy. Can anybody think of why it would take that long?
I would think a lot of it might have to do with, it's somebody's just been severely traumatized, so they may need to take breaks throughout going through the whole process.
Yeah, you're definitely spending your time taking careful attention to the patient, not interjecting, all of those things. Yep.
And also that all these things you want to really be careful as to not contaminate. So that's just what comes to my mind.
Glove changing every collection you do, and the drying of the swab. So we're have a wet specimen and we need to make sure that it's pretty air dry before we put it in the container. So that takes about an hour in itself. And as a general rule, I do not, unless the patient's kind of by themselves and wants me there, I do not like to be there during the police interview, because I'm held liable for all of the things that are said during the police interview. So I don't have all that capacity in my head to remember all of those things. So yeah, the police interview usually takes a long time too. So the patients there are a good 3 hours generally. Okay, so furthermore, on some documentation of the female, it's good and helpful to know kind of what we're looking at. If you look at that red area, that's the down at the very far Y there, that's that area. Well, here, let me point. Right here is called the posterior fourchette. That is oftentimes injured, if there is any injuries on a rape, as well as this whole area called the fossa navicularis. So if you want to get technical, bring out an anatomy book while you're doing this, and make sure that you're hitting those highlights. The posterior fourchette, the fossa navicularis are the big ones. And then I have a couple of case scenarios that I would like to go over, and then we'll break into the kit itself. So a 28-year-old female presents to the emergency department at 10 a.m. on a Sunday. This happens a lot, 10 a.m. on Sunday. She reports she had been to a couple of bars with friends the night before. She loses some hours and wakes up in a house not known to her. She calls a friend to pick her up, and they come straight to the ER. She has contusions to her neck and in her thighs and a black eye. She has mild vaginal bleeding. So first question, was she raped?
Not our job to decide that.
That is not for us to decide. Perfect. Here, what labs or diagnostic images do we think that we might need for her?
We might want a head and neck CT because she's got contusions and a black eye and stuff.
I like it. Yeah, neck CT, and then, yeah, CT of the head too for that black eye. What is that one thing that we all hate doing because it seems so benign? That Snellen chart, right? Get a visual acuity on her. What else might we consider?
Maybe a pelvic exam.
Okay, yeah. So what barriers do you think this person has to report? And actually, Jennifer, this kind of looks like it was right up your alley for your case. First of all, we talked about it, she doesn't remember, right? Anybody think of anything else?
Would we want to do a toxicology lab?
Yeah, I think that's good.
I think in this girl's case too, yeah, the fact that she didn't remember, so it's like I don't think she knew the perpetrators. So
Yeah.
it was like well, I couldn't, she may not understand the process or, collecting DNA, and she may not want to have gone to go through all that, especially because she doesn't have support. I mean, she's homeless. She doesn't have family and friends, a good support system. And so for her to go through that is probably hard for her. And not understanding like all the things that can be done, even if you can't name the people who did it.
Yeah, lots of all of that. So Christian brings up, do we want a toxicology? In our emergency department, we are able to do 8 drugs. We really would love to get the patient's very first urine, and we don't have them clean. And what happens with that first urine is I will take 1/2 for the crime lab, and they are able to do a full panel of all of the drugs, and then do a crime or do a tox screen here. We also do pregnancy tests, because if we're going to give the patient prophylactic medications, they probably shouldn't be pregnant already. Yeah. Anybody else have anything to say here?
Do you guys, and this might be like a weird question, but do you guys give them like plan B or something, or you offer it, or?
It depends on the hospital, unfortunately, that you're at. So some have highly religious affiliations and will not offer plan B, but most will offer a plan B for that patient. Yeah. Anybody else think about any kind of barriers or diagnostic images since we're back there, or labs?
As sad as it is, she may feel responsible, even though she's not, because she went out drinking at bars and may think that she blacked out because of her drinking, which is, I mean, we all know is complete crap, but that she's not responsible, but she might feel it.
Yeah, for sure.
Yeah, that my patient, I think, has a history of drug abuse. And so whether she had been indulging in drugs or was given drugs on top of that, whatever, and didn't know what she was getting, but I, made sure she knew that it does not matter. You did not deserve this, and it is not your fault.
Yeah, absolutely. Yeah, so some of those date rape drugs like Rufinol, that goes out with the first urine. So if you can, try to collect that first urine. Here's another thing to note. Once you've collected it and it belongs with the crime, and you're gonna submit it for forensic evidence, it does not leave your site. That's called the chain of custody. So, okay, so how will the same nurse proceed?
I don't know if this is the first thing we do, but making a report to the correct law enforcement or things like that.
Does this patient have a right to not make a report?
Yes, they're 28.
Yep. So yeah, we will call law enforcement on their behalf if they don't have any objections to it. We will use our trauma-informed care. We will complete our documentation. We will obtain the patient's consent. We will complete the forensic collection. We will make sure that the patient has a safe place to go. All of those things. I have another interesting case scenario. Would anybody like to read this out loud instead of me?
Sure. A 16-year-old female is brought in by her parents after she was caught having sex with her 20-year-old boyfriend. She and her parents are both crying. Her mother tells you the sex appeared rough, like he was trying to hurt her. She also states he is bullying her. Oh, sorry. He is buying her expensive clothes. That's why she keeps him. Father is staring at the same nurse in an intimidating stance. Patient reports repeatedly, he loves me.
That's review of systems is within normal limits. So was this patient raped?
Not for us to decide.
Legally, isn't this statutory rape?
I would agree because she's a minor.
So let's go into this next slide. These are
Doesn't it
Washington.
depend on what state?
Yes, states are hugely different on this. And so I have the Washington state age of consent. Here's the first thing, consent for treatment. So anybody that's 14 years of age or older, if they come in with anything sexually or mental health, they don't have to have a parent with them. They can get, they can be seen. So consent for treatment is 14 years of age. Consent for sex, this is something totally different. This is in Washington state. In some states, it's 18 and over. So really know your state, but in Washington state, someone 16 and over. Exceptions are if the older person is a foster parent, a teacher, or older than 60 months of the victim, and supports him or her, also known as significant relationship. So we have to decide what 60 months is. Is that 5 years?
5 years.
So in our scenario, we have a 16-year-old and a 20-year-old. Technically falling under that age of consent. If we're just going on that.
Some of this stuff is just like, wow, under 12, what?
Yeah, so if you're 14 or 15 and are less than 4 years apart from each other in age, then that is considered consensual. Someone that's 12 or 13 if less than 3 years or older, that's considered consensual. And someone under 12, if you're less than 2 years older, that's consensual. Yeah. All right. So what are some barriers to this scenario?
Her parents are there.
Yeah, we have.
Her father being understandably in an imitating stance.
There's a lot of things that the nurse has to negotiate here, isn't there, to make everybody happy. Anybody think of anything else off the top of their head with this scenario?
Wouldn't she, I mean, based on the laws, the laws for the girl to be able to get care, I mean, wouldn't the nurse basically just say, unless you want your parents in the room, you'll need to step out while we talk about this?
Yeah, I would definitely interview her alone. it's tough. Like Chandler said, you know, those parent instincts kick in, and parents want to be there with their daughter. What about this quote that says he's buying her expensive clothes and that's why she keeps them? Can anybody think of something else that might be going on here?
He might be grooming her.
Yeah, sex trafficking. So they actually have in Epic some sex trafficking questions there if you suspect that. Then when you interview the patient, then all of your questions can, you know, or some of your questions can steer towards that, about, you know, asking about the patient's, you know, safety and things like that. So yeah, the sane nurse proceeds in really a cautious stance here because everybody's going to be upset. She's upset that her parents brought her in. You know, does she even need to be here? Does she have a right to leave? All of those things, right? So yeah, too bad he wasn't 21. I only could say, yeah, it was rape. We're definitely going to report this. All right, we will take like a 10-minute break, and then I'm going to go over the kit with you, and then we're going to be done. Sound good?
Could you post the
Yes.
slides during break?
Yes, I was just gonna ask the same thing. Thank you, Cindy.
Sure.
Thank you.
Mm-hmm. All right, I have hit the record button and it is now 10:23. So we'll get into that kit and then we'll call it a day, okay? So this right here is what the kit will look like. And we have some patient identifiers up top, and it is always important that we're not breaking the chain of custody. So this right here is who is giving the next or the, like, you know, law enforcement, and what time, the date and time it was received, and signatures for both. And then when the kit is all said and done, it gets a bunch of evidence tape on it right here. And so this kit is sealed. The urine does not go in here, and neither does the blood. And the blood is also for toxicology. When they do the kit too, they want to know the person that's doing it, your full name. So if your DNA happened to get in on the kit, then they will sometimes take a DNA profile from you. But we're going to try our darndest to not make our DNA evidence on that into that kit. Okay, so we will open that kit. This is really hard to do on Zoom. And this very first sheet will actually kind of give you instructions on what to do. So if you freak out for the first time, are told to do this, and you don't have never had any experience doing it, definitely have these instructions available. But each one of the steps here has instructions as well. So the first thing that they do is urine toxicology. That's step one. And that's urine toxicology. And it tells you exactly what to do. It says collect when there's any concern for intoxication or date rape drug within the past 72 hours. You want to collect 50 milliliters of urine in a standard specimen cup, and then transfer to a state toxicology container. They actually don't have those. We use urine cups, and then put evidence tape on it, and then place the patient ID label on the container, put it in a biohazard bag with one paper towel, place this label right here on the bag, and place the patient ID label on the outside of the bag as well. And then you'll want to refrigerate, freeze, or leave at room temperature until transfer. So if we have issues with urine toxicology, we want to get that over to the law enforcement as soon as possible. And it says, do not place an evidence kit. So then it asks here, was the urine toxicology collected? Either yes or no. And if no, is it because there's no history of intoxication, if it's more than 72 hours since the assault, or the patient declined it there? And then we move on. Okay. And then the next thing we do is step 2, and that's our oral swabs. In oral swabs, we should collect in all cases, even if the patient is ate, drank, rinsed their mouth after the assault. And the kit has just a ton of these little Q-tips. And I'll break one open. What should I have done before this? So my DNA.
Put gloves on.
So my DNA isn't on here. Yep, wash my hands and put the gloves on between each step. So these they're just, you know, when you break it down, I tell the patient it's actually just some Q-tips, some really long Q-tips. It says use 4 cotton swabs total. Do not moisten. Use 1 swab at a time. Swab around gingival border, at the margins of teeth, buccal and lingual surfaces. Repeat with the 3 swabs. So when it's a pediatric patient, I tell them I'm gonna go brush their teeth. They think that's kind of funny. It's like one thing that we can do to break the ice there. It's like, I'm just gonna brush your teeth here. Get your tongue, get around your gingival borders there. And then we allow swabs to thoroughly air dry. That's what it says. Then it says place swabs in swab box, 2 swabs per box, and you'll want to write oral on the swab box. Place both swab boxes in this envelope and seal the envelope with the evidence seal, then initial and date, signing on seal and onto envelope. Then you'll want to complete information on the back of this envelope and return box or envelope to box. So lots of things that need to be done. This is the back here. So as you can see, this is where you put the evidence seal, the patient's name, the date that and time it was collected, and your signature. And did you collect the oral swabs? Yes or no. And if no, because the only reason why we wouldn't collect them is that the patient declined. So we literally take these swabs, put them in a place to air dry. Then we want to, after or while everything is drying, make up one of these little boxes. We'll write oral on there. We form our box. We place those 2 swabs in there after they've dried. We close this. And you'll have a total of 2 boxes on this. Then we put it in to the envelope. Prior to that, we should have filled out most of this, so we're not writing on a bumpy surface. These right here are evidence seals. So we put the sticker on here and seal it. And then right here, I don't know if you can tell, is the date and the initial of the person sealing it. So what you want to do is make big date that comes all the way into this paper, and as well as your initials to show that the seal has not been broken. So you'll make a big loopy initial right here. All right, so that's the oral swabs. Everything gets a lot easier here. This is trace debris. So if the patient, just like in Jennifer's case, was found naked and maybe outside, there might be some trace debris. So they might have picked up things around their surroundings. So whether it's, on a mattress that's foreign to them, or they're out in like in the woods or something like that, you'll want to have the patient take off their clothes onto literally just this piece of tissue paper, and you want to spread it on out and have them take off their clothes, and then whatever drops into here, and then you'll just fold it back up and in a nice way so it puts back in here, and all of a sudden they have their trace debris. Now that we have their clothes, we can go to step 4, and this is their outer clothing. So you'll want to collect everything except the underwear. The underwear goes into a separate bag there. And then there's specific directions about their outer clothing. It says, collect when the patient brings in or is wearing wet clothing worn at the time of the assault. Place each item of clothing into a separate paper grocery bag. Do not cut through any existing holes, rips, or stains. Do not shake out patient's clothes, or trace evidence may be lost. Place this label on each bag. Place the patient ID label on the bag, and write contents on the outside of each bag, for example, jeans, and then tape each bag closed with clear packing tape. If there's wet clothes, you want to place it in a double paper bag, place it in an open plastic container or an open plastic bag, and label wet to transfer to law enforcement within transfer to law enforcement within 3 hours. So there's the outer clothing. And then you'll put this on the entire transport bag. We're already on step 5. So you will label everything in this outer transport bag, which is generally I make like each clothing into a paper grocery bag, but I make it small and then have the clear packing tape on it, and then put everything into this into a larger grocery bag, and then place that on top of it. And then once again, you're putting your big old swoopy initials on it whenever you have a seal. Okay, and then this is where the underpants go. So whether the patient has changed their clothes or not, you still want to collect the underpants because there might be some residual DNA on there. This is an old kit because this says pulled head hair, and we don't do that anymore. So I'm going to skip this one. We don't take the patient's hair from their head. Okay, the next one is fingertip swabs. And this is where we get to bust out our distilled water. So each kit comes with this little distilled water. We grab our Q-tip. And one of them gets distilled water on it like this. Just 1 or 2 drops per hand. And we'll remember left hand and right hand. And then you'll want to go kind of into their fingernails like this, or around their fingernails like this, and then definitely like in each of their fingernails. So for our kids, you know, they're getting manicures and, you know, manicures, I guess. They also think this is funny. Each one of these with a wet.
Every time you talk about doing this for a kid, it just makes me sick in my stomach.
It's awful. Yep, and that's what you'll more or less get the subpoenas on, it seems like. Have to testify in court. So wet and then dry, and then everything gets set aside to dry. So we've made ourselves little labels that say, you know, skin, right hand, left hand, all these things. So while they're drying, we can keep tabs on them. But I do it the same exact way every single time. So yep, we'll leave those aside. And then label the boxes very similarly as we would the oral, right hand, left hand, put 2 in each. Seal it up with the evidence tape and you're done with that one. All right, and then step 9 is reference blood. Let me see if this is in here. I've been through this kit quite a bit. Oh, of course I don't see it. But here's a little capillary glucose monitoring kind of stick, Lancet, if you guys remember that. It just works exactly the same way. And really, it's just a card on there where you just, it has 4 little spaces. You only need to fill up 2 with basically 2 drops of blood apiece. And this is so they can distinguish the patient's own blood or DNA from the perpetrator's DNA. And then after that dries, the card goes into here, it gets sealed and is done. Okay, and then if there's any remaining debris on the skin, this is already step 10, debris on skin. On the back here, it's got like a little anatomical chart where we did take that debris from the skin. So, you know, once again, if they were out in the woods or got something going in their hair or whatever, we're gonna take the debris from there, and it's literally same concept as before. It's a piece of paper. So we're gonna use that Q-tip to kind of shake off any kind of debris in the skin and hopefully kind of collect it right here. And then fold it, stick it on in there. And then with that, this anatomical area there, we would label where we took it. So skin swabs, this says collect when patient reports possible saliva, semen, or lubricant on the skin, even if the patient bathed prior to the exam. You'll do this with like suction ecchymosis. That's what they call hickeys. So if you guys learned nothing, you've learned that today, that the patient has received a suction ecchymosis. So they will, you know, I always ask if there was any place, I ask the kids always if there's anything, you know, wet or gross on them. But I'll ask, you know, an adult if there was any place that they were, you know, licked, kissed, bit, or otherwise. And then you'll take specific areas on there and then try to label it on the back. You can take several different ones. So, you know, they have a hickey on their neck and they have, you know, maybe the perpetrator ejaculated on the abdomen or something like that. You'll take multiple different sites if you need to. This one's interesting. It's pubic hair combing. This has kind of fallen in and out of practice as trends have come and gone. But the patient should be really sitting or lying in dorsal lithotomy position. So think about how you would be if you had a pelvic exam. And then we have our tissue here. And if they have pubic hair, we're obviously gonna do it. If they don't, we don't. And then kind of stick this under their bum, and then it comes with a comb. So you'll comb down. And oftentimes I will have the patient do that themselves. I'll kind of monitor it, but you know, it's like a good intro into the more private things that you're about ready to do. This is a really old kit because this says pulled pubic hair and we don't do that. Okay, so the next are going to be steps 14, 15, and 16 are our perineal and vulvar swabs, vaginal and endocervical swabs, and anal swabs. And I try to do these kind of all at once. Unfortunately, we can't use lubricant on this because the lubricant may actually interrupt our like the DNA and enzymes, and we won't get a proper collection there. But they, you know, if it's an adult female, we do the perineal area and the vulvar area. We label those as perivulvar. We can use a little bit of that, the distilled water on there, but mostly we're going after it with the distilled water into the labial folds and the perineal area. And then when we do the vaginal and endocervical, I feel like that's a great time to do a speculum exam if it's indicated, and we just have to use warm tap water for lubricant for that. And then that would be a good time to use the Toluidine Blue that you guys have talked about last week. All right, and then the anal swabs the same way. And when the patient's lying on their back, we use the clock as the numbers there. So I'm gonna go here. This would be like the 12 o'clock position, you know, from the back, 12 o'clock position, 1, 2, 3. Or maybe I did that opposite, but you guys get the drift. All right, and then the distilled water and the controlled tabs has its own little its own little box, just to make sure that the control is as it should be. So it just says lightly moisten 2 swabs with the distilled water provided in the kit. Allow both swabs to thoroughly air dry, and place both swabs in the swab box and write control swabs on the swab box. Return swab box to this envelope, seal with an evidence seal, then initial and date the seal, and fill out all information requested on the back of the envelope and return to kit. So the first few times I actually did this, guys, I read it to the patient. I said, okay, we're gonna do exactly what it says here. So this, I'm gonna lightly moisten 2 swabs and then place both swabs in the swab box. Okay. And then after that, like I said, we're gonna allow everything to thoroughly air dry. And while we're doing that, I know at Cadlick we have, well, supposed to be a locked box, but it's really not. So if the nurse needs anything, we have to put the call light on because we have to keep a visual eye on all of this stuff while we're doing it and allowing it to dry, all of that. So we might have to enlist the help of our friends to get us anything. And I like to do, I don't know if anybody's had a gram of azithromycin, but it can make people have diarrhea and make them feel really nauseous. So I like to make sure that, like, while I'm waiting for the swabs to dry, that I've gotten the patient a little something to eat prior to that, if they can, and then give them their antibiotic at the very last, because that can make their stomach a little bit upset, especially if it's on an empty stomach. So yep, after all that, then we call law enforcement, and we have to call the area where the patient where the rape reportedly happened. So we have a lot of people come from like Desert Air and Mattawa. We have to call Grant County sheriffs, things like that. So get it to the proper law enforcement. And then we submit it to Washington State Data Bank. And each patient is given like a username and like serial code for that, so they can kind of keep an eye out on the status of their collection kit. And the last I heard, they are about 18 months out on their collection kits. And if that doesn't like make you mad, then nothing should. All right, well, that's that. Anybody have any questions about the collection itself?
I have a quick question. When you're letting the swabs dry, is there a specific place that you put them? Like, do you put them back in the wrapper? Do you put them in the box before they dry, or how do you do that? Where do you put them?
Each place is a little bit different with what they do, but they don't put them back in the box because we don't want any kind of moisture in that box. But we have like a little, you know, where they put tubes in at the lab. There's a little like crate looking thing that we'll just put in there and then put labels right next to them, so we know exactly what the labels are.
Okay, yeah. Perfect. That makes sense. Thank you.
There's some hospitals too that have a heater, like a dryer, that kind of uses air circulation to help dry those specimens too. So it's important that they're dry. It just takes time. We're generally about an hour. Any other questions? Or not?
I have a quick question, Karina. Just like, I'm thinking more like logistically, if you're the nurse for a patient and you're like preparing to go through this whole process, would you just like talk to your other nurses and be like, yeah, I'm going to be in this room doing this kit for like 2 to 3 hours. Can you watch my other patients? Or what do you do with your other patients?
Great question, Sydney. This is definitely a one-to-one patient. When they come in, we give them an ESI of 2. So that's a really high one, right? And they definitely are a one-to-one patient. Cadlick, it depends on the availability of nurses, but more often than not, they will try to send out a text to see if someone can do a collection. And the ER nurses are the only ones that do it. So like, for instance, a couple of months ago, I did a kit up in the ICU. They had to wait for like 4 hours for me to get off of my other shift. So, but yeah, they're definitely a one-to-one patient. All right, anything else? All right, well, I'll post this quiz and I hope you guys have a great rest of the day. Oh,
I have a quick question, but it wasn't related to that. So I was waiting for you to wrap that up to make sure I wasn't interrupting.
Sure, no, go ahead.
I'm a little confused on the domestic violence and abuse PowerPoint. There was no video. What are we doing with that?
I'm doing a live lecture next week.
Okay, perfect. Thank you.
Yep.
Is that what you said when I first came on?
Oh.
I felt like it might have been that, but I wasn't sure. So I just wanted to be sure.
Yeah, I might have said it. I might not have.
Thank you.
All right. Do you guys get to go into CBC today?
Yep.
All right. Well, go after it.
Thank you.
Oh, can I ask you a quick question, Karina?
Sure.
This is kind of related to ER. So when we do like UAs in the ER and we're getting drug screening or alcohol screening or anything of that matter, is there a policy on like, are we not supposed to tell the patients what we're getting from them as far as the sample, or why don't we say anything? Are we not supposed to? We're not supposed to say, hey, this is to test your urine for drugs and alcohol. But we don't say that. And it's like an unspoken rule. And last week, my fiance was in the ER for dehydration and they took his pee. And I was like, oh, I know what that is. And they
Well,
didn't tell him. They said, this was for
probably-
your abdominal pain.
They probably took his pee for, you know, to determine specific gravity and see if there's any proteins in there.
They did a drug screen.
Oh, they did too?
Yeah, they did the full workup and he was fine, but he was also like, they said it was for my abdominal pain. And he never said that. He was just dehydrated.
Yeah, I mean, technically the patient has a right to know what they're in there for. Obviously there's that implied consent thing that's happening if they're, you know, not conscious or for some reason out of it. But we, you know, like our mental health patients, they have to get drug tested as well. And, you know, we have to tell them you're
Yep.
supposed to.
We tell
So that
all of ours
so-
know what they're getting tested for.
my fiance didn't know and they didn't tell him. And when they discussed his discharge, he didn't even bring it up. He saw it in his my chart and it was just like, it was just kind of a thing that I was like, they were very hush hush about. And I was like, is this like a policy? Doesn't he need to be informed that what he was tested for?
Yeah, I mean,
Technically, yes.
technically you're supposed to tell them
Okay, that's what I thought. I was like, that's weird. They didn't tell you anything, but I know you got a drug test.
Yeah, the funniest one I've seen was the patient we had like given narcotics to, and then we asked for some urine and drug tested him, and he came back completely negative. We're like, who peed for you? It's like, we know
Okay.
this isn't your urine. It should be at least positive for this because we gave it.
Right?
To you. But,
Okay, so it's just like for mental health issues, then
no,
they
I
don't
mean,
need
for
consent.
everybody, yeah, for everybody, you should tell them why you.
Everybody. Okay.
Mhm.
Okay.
Yeah.
Thank you.
Mm-hmm. All right. Anything else?
I have a
What is the
quick
question again?
question, but you don't have to record if you don't want to.
Okay. Well, I'll stop record then.